Well, thanks very much, Ken. And, my job is to talk about two different systems here in the same talk. My disclosures. So both of these devices intend to address issues that related to vascular characteristics that are not ideal. So on the left-hand side here, you can see an idealized characterization of a drug-coated balloon where there's a relatively thin mantle of atheroma, and there's a relatively easy barrier to cross for drug delivery. But in actuality, many of our patients have lots of medial calcinosis or calcification. Many have bulky, heavy atherosclerosis, and not infrequently we see chronic and sometimes acute thrombus. So what's the operative issue here when you start to talk about delivering drug off of a balloon? The BullFrog device is actually a family of devices that you can see how they work here. The device has a needle which extends on balloon inflation. There's an elastomeric balloon on the back end which can be inflated to fit the vessel depending on its size. It's currently FDA cleared and CE marked, so it's available for use outside of a trial. Basically, it's agnostic to the type of agent which is infused. Any agent really could be infused as long as it's in solution, and it's typically mixed with diluted contrast so that you know that you've delivered into the adventitia. You can see here on the right-hand panel, the end result looks like a little bit of a cloud around the vessel. We do have data from the BullFrog device, actually randomized data, a small trial called Tango, which is a phase 2 prospective multicenter randomized double-blinded trial which intended to look at the treatment control versus BullFrog in a 2-to-1 randomization with two different doses which had similar outcomes, which we reported together here. Again, a small study, about 40 patients altogether. And what we see is that the primary endpoint, which was a angiographic T-vol, which is a transverse view area loss, which takes into account all of the segments, not just the worst segment of the vessel treated. And you can see the key secondary endpoints here, which include clinically driven TLR, amputation, and re-occlusion. And on the right-hand side, the published data shows that as compared to control, in this relatively small trial, we can see that there was a meaningful effect in terms of target lesion failure, with 74% of the patients achieving patency at the 6-month mark, as opposed to control of less than 50%. Moving now to the retrievable stent therapy, or the temporary Spur stent system from Reflow Medical. This is a retrievable non-implantable stent which has these spikes on them, and the spike design is intended to modify the vessel calcium and potentially reduce recoil, reduce dissections, and improve drug uptake when used with a DCB. And again, this is agnostic to the type of DCB which is used. In animal studies and preclinical cadaveric work, you can see that microscopically here on the right, that there's a nice channel created through the vessel with these spikes. And here you can see the spikes actually protruding through calcification. So the intended design appears to be effective. This is a non-randomized trial, larger than the previous trial from BullFrog. And if you look at the outcomes of primary patency at 12 months, not 6 months, we see that the per protocol patency is about 80%, and clinically driven TLR is nearly 90% in a BTK study. So in conclusion, both Mercator BullFrog and Reflow Spur systems target the adventitial drug delivery with antiproliferative therapies. The Spur system is done by creating channels that allow for DCB infusion, so to speak, and the BullFrog through direct injection of a therapeutic. The Spur system also hopes to reduce recoil by vessel modification with these numerous spikes. Both systems are addressing the issue of drug delivery in challenging scenarios, thick atheroma, calcium, and so on. The BullFrog appears to have a significant therapeutic effect in a small randomized trial, and the Spur has also developed favorable data in a single-arm study. Thank you very much.